This cricket study addresses the issue of whether or not we can re-challenge patients who've previously gotten worse on a therapy. So in other words, you try to, an approach in the first or second line setting, the patient got worse, they get some other drug. Can you go back to that first drug? And what is the role of the biomarker testing, in this case circulating tumor DNA? We know that RAS mutations are a marker of resistance for an EGFR targeting monoclonal antibody. And we can't biopsy every single tumor in a patient. And so by taking a blood test, we're trying to get an idea of the total burden of disease throughout that patient and whether or not there are clones of cells that have a resistance mutation, in this case a RAS mutation. This is a very small study. It's less than 30 patients. The responders were sort of 4 to 6 patients, depending on confirmed or unconfirmed. So this is a hypothesis-generating trial. But nonetheless, it indicated that for patients who did not have detectable resistance mutations, they seemed to get the benefit from a re-challenge. So basically, the biomarker studies confirmed what we would have hypothesized, which is if you don't see a resistance mutation, you would be more likely to get benefit from re-challenge. And on the other hand, if a resistance mutation exists within your total tumor burden, you're less likely to get a benefit. In colorectal cancer, some of the most promising studies that I've seen in the last few years have to do with biomarkers and both screening and adjuvant therapy regimens. The most interesting data I've seen for quite some time is circulating tumor DNA to see who actually needs adjuvant therapy and who doesn't, and also circulating tumor DNA to pick up biomarkers that could be potentially actionable, and also to be used as a screening test, as a cheap, non-invasive screening test for all sorts of DNA mutations that could indicate several different cancers, not just colorectal, but lung, pancreas, breast, other studies. These are all initial studies. It's not ready for prime time, but it's quite possible that in the next decade, instead of having an expensive, invasive colonoscopy that costs thousands of dollars and many Americans don't like getting, that we could just have a blood test that looks for mutated pieces of DNA that just shouldn't be there in a normal human. And if the test is positive, those are the patients that then could be referred for more invasive testing, presumably just a small subset. So it would be cost-saving, and it would spare the discomfort or any other issues with the more invasive, expensive screening tests. Similarly, for patients who've had an operation and where you know what the circulating mutated DNA could be in their body, following the operation, if the circulating tumor DNA has been cleared and it's not evident, those patients may not need postoperative therapy. Alternatively, if you still are detecting abnormal pieces of DNA in their bloodstream, those patients might be the ones where you have to use very intensive therapy. So that, I think, would be incredibly promising to pick up cases earlier. We all know that colorectal cancer is occurring in people in their 30s and their 40s, which is why the American Cancer Society recently changed their guidelines. Instead of waiting until age 50 for average risk, they're saying we should start getting colonoscopies at age 45. It's reacting to this younger patient population. But wouldn't it be better if we could just do a blood test instead of these more invasive and expensive tests to try to detect who needs to have more extensive screening and just leave the other people alone and they don't have to have additional testing. And I look forward to that day to really help cut down on the incidence of colorectal cancer and help guide us on who needs to be treated after surgery.